بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everybody to this activity. I'm very proud to be part of this well-renowned group. I will be glad to moderate the session and to present to the two speakers. As you know, diabetes is one of the major chronic disease in Saudi Arabia and the rest of the world. And one of the things that drive the cost of diabetes is cardiovascular mortality. And for years and years, us as endocrinologists, we have been looking for treatment, and many drugs has been tested. The aim was to reduce the burden of diabetes and to reduce namely the cardiovascular morbidity and mortality in patients with diabetes, to have lower cost and better economy for taking care of this big segment. However, many failures have been throughout our history until SGLT2, GLP-1 came into the picture recently. So I feel very happy to live in this era that we finally have medication that improves patient quality of life, medication that lowers cardiovascular morbidity and mortality. So what we are aiming to in this event is to shed more light about SGLT2 inhibitors and its role in cardiovascular morbidity and mortality in patients with diabetes, and also to highlight other potential benefits of these classes. I would like, first of all, to thank Boehringer Ingelheim for composing and arranging this amazing event. Very exciting topics and two well-known speakers. For your questions, I would ask kindly if you have any question throughout the two lectures, type it, and we will address those questions at the end of the second session. We'll start now with the first session with Dr. Ali Youssef. He is a consultant intervention cardiologist in Saud Al Babtain Cardiac Center in Dammam, Saudi Arabia. He's assistant professor of cardiology at Suez University, Egypt. So, Dr. Ali, I will give you the mic.
Thank you, Dr. Abdullah, and thanks for the Saudi Heart Association and Boehringer for organizing this important meeting. We hope it will be of great impact in the medical practice and with the final benefit to our patients. I will start the first talk in this session with the evaluation of the standard of care in cardiovascular risk management for type 2 diabetes. Cardiovascular and kidney disease are major contributors to the burden of type 2 diabetes. Kidney disease has great impact because it is prevalent with high morbidity and mortality even. And cardiovascular disease is another important factor, either through the atherosclerotic ischemia-driven bad outcome, or even ischemia-independent cardiac morbidity through heart failure development in patients with diabetes. Approximately 50% of patients with type 2 diabetes still die from cardiovascular disease. Despite all the trials and all the effort done to date, still the major mortality from diabetes comes from cardiovascular events. If we take the patient who is 60 years old and he is having diabetes, his life expectancy is reduced by 60%, by 6 years. Coming from increasing kidney disease and cardiovascular adverse points, as we mentioned, that 50% of patients with type 2 diabetes dies from cardiovascular disease, and the life expectancy is reduced by 12 years in patients with diabetes and cardiovascular disease. So it is important to reduce the risk of premature cardiovascular death. Is important and is priority to manage patients with type 2 diabetes. Unfortunately, another burden comes from the heart failure, as heart failure is a common comorbidity in patients with type 2 diabetes. And around 15% of patients with type 2 diabetes also have heart failure. And there is 2.5 times higher rate of chronic heart failure in patients with diabetes compared to patients without diabetes. Essentially, 50% of patients with type 2 diabetes also have some chronic kidney disease. And the rate of heart failure is 3 times higher in patients with chronic kidney disease. So there is interaction between diabetes, heart failure, cardiovascular bad events, and chronic kidney disease. Patients with diabetes are at higher risk of kidney disease. And the chronic kidney disease, as we said, is found in almost 50% globally of type 2 diabetes patients. And diabetes is the most common reason for progression to end-stage kidney disease in many parts of the world. Compared to patients without diabetes or chronic kidney disease, the presence of type 2 diabetes is associated with excess mortality of 4.1. And if the patient with type 2 diabetes got albuminuria, there will be excess mortality of around 18% within 10 years. And the mortality in 10 years will be increased by almost 24% in patients with type 2 diabetes and declining estimated glomerular filtration rate of less than 60 millimeters per minute. And you can see that there is almost 47% excess mortality within 10 years if the patient with type 2 diabetes is having albuminuria and reduced estimated glomerular filtration rate. Now we are not talking only about glycemic control, but now we are talking about the multifactorial management as a well-established standard for care in patients with diabetes. The global risk together. The American Diabetes Association recommended that the management of patients with type 2 diabetes should include blood pressure lowering, and as per the ADA guidelines, blood pressure less than 140 by 90 millimeter mercury, and we know that other guidelines even go lower to 130 by 85 or 130 by 80 as nice guidelines. To reduce the LDL cholesterol to with the maximum tolerated high intensity statin essentially, smoking cessation, and to individualize the lifestyle and diet, to encourage weight loss as per ADA, to reduce weight in the obese and overweight patient by 5 to 7%, and to have glucose control. And again, for the ADA, they still recommend HbA1c less than 7%, but of course this figure should be manipulated according to the age of the patient, additional risk factor or comorbidity, and the duration of diabetes, and we will discuss later. So what does the care of diabetes mean to the patient? We should recognize importantly that the cardiovascular disease remains the leading cause of morbidity and mortality in patients with type 2 diabetes. And importantly now, the arrival of new agents that is proven to reduce the adverse cardiovascular outcome in patients with type 2 diabetes should trigger a major paradigm shift beyond just a simple glucose control to have better cardiovascular outcome and reduce the cardiovascular risk. The evidence of the positive cardiovascular outcome remains limited with the older glucose-lowering therapies. Here we talk about the older therapies, including the metformin, sulfonylureas, and the TZDs. For example, the metformin had just shown modest benefit in the long-term follow-up of the UKBDS trial. And there is limited evidence for metformin from large, long-term, placebo-controlled cardiovascular outcome trials. And for the sulfonylureas, the cardiovascular safety of most sulfonylureas has not yet been established in long-term cardiovascular outcome trials. And there is heterogeneity about the safety of this agent to date. The major concern actually of triggering the request of cardiovascular outcome trial came from one agent of the TZDs, which is the rosiglitazone. The rosiglitazone, at the year 2008, we have a lot of news about increasing cardiovascular mortality through increasing heart failure and myocardial infarction. And since this time, it is important to consider two things. Number one, it is not only the intensive glucose control that we should strive for, because most of the meta-analysis of the large conducted study in this aspect, including the advanced, UKBDS, ACCORD, and VADIT trial, meta-analysis here has shown it did not show favorable outcome in cardiovascular events with intensive glucose lowering regimen. Not only that, if you look carefully at one of the studies, for example, the Accord trial that compared the intensive glucose lowering with H1C less than 6.5 compared to the standard glucose lowering, it was associated with increased all-cause mortality and cardiovascular mortality in the intensive glucose lowering arm. And since the year 2008 become prerequisite for the glucose lowering agent to provide cardiovascular outcome trial to prove safety, at least safety in the cardiovascular outcome. And the more recent glucose lowering agent, including the GLP-1 receptor agonist, the sodium glucose cotransporter 2 inhibitors, and the DDP4 inhibitors, had run several studies in this concern. The recent development of the sodium glucose cotransporter 2 inhibitors and the glucagon-like peptide 1 receptor agonist has demonstrated that treatment developed for the glucose lowering not only will get us better glycemic control, but importantly is have direct good outcome on the cardiovascular events. And there is need to incorporate the use of these agents in patients with type 2 diabetes with clinical evidence of atherosclerotic cardiovascular disease purely to optimize the cardiovascular outcome independent of its glycemic control effects. Putting the evidence of the most of these studies together in this slide, the evidence here for the two important glucose lowering agents, the sodium glucose cotransporter 2, including the empagliflozin in the EMPA-REG outcome trial. You can see that the empagliflozin was associated with 14% relative risk reduction in the 3-point MACE. 3-point MACE, it includes the cardiovascular death, non-fatal stroke, and fatal myocardial infarction. It also was associated with 38% relative risk reduction in cardiovascular death and 35% relative risk reduction in preventing heart failure and reducing hospitalization for heart failure. Canagliflozin, the CANVAS program, had shown significant reduction in the 3-point MACE and hospitalization for heart failure. And the dapagliflozin, the DECLARE study, had shown significant reduction of hospitalization for heart failure. The other important group that have shown favorable cardiovascular benefit is the GLP-1 receptor agonist. We have here the liraglutide had shown significant reduction of the 3-point MACE, essentially through reducing cardiovascular death. Also, the semaglutide and albiglutide had shown significant reduction in the 3-point MACE. Looking carefully at the EMPA-REG outcome trial, because this was the first one to show this very robust benefit in terms of cardiovascular events. The study had run in 590 sites in 42 countries with 7,020 patients randomized, and more than almost 79% of the patients completed the trial, and the vital status was available in more than 99% of the patients. So it is a model of good study. All the patients had type 2 diabetes with established cardiovascular disease. The patient had been randomized into 3 groups. All the patients are getting standard of care. 1/3 will have been randomized to placebo on top of standard of care. 1/3 to empagliflozin 10 mg once daily, and the last third into empagliflozin 25 mg once daily. You can see here the impact of empagliflozin on top of standard of care on reducing cardiovascular mortality, 38% relative risk reduction. You can observe that the beneficial effect of empagliflozin on top of standard of care started very early before any noticeable significant glycemic control. So it works by something away or beyond the simple glycemic control. And the benefit is sustained with more wider diversion of the curve. And even if you look at the end of the study, the curve is far away from the benefit is far away, increasing with using empagliflozin in terms of cardiovascular death. What about hospitalization for heart failure? The population in the EMPA-REG outcome trial had baseline heart failure in around 10 to 12% only of the population. And you can see throughout the study that ran for around 3.1 years, there is significant number of patients in the standard of care had developed new heart failure and needed hospitalization for heart failure. While in the group that had empagliflozin on top of standard of care, they had significant reduction of new heart failure and hospitalization for heart failure, 35% relative risk reduction. So in this population, we can claim that clearly from this graph that empagliflozin is one of the drugs that can prevent heart failure. Look again at the start of the curve. The divergence is very clear, significant, very early when starting the intervention with empagliflozin, and still the benefit sustained with wider diversion of the curve as we go throughout the study. Important to know that the impact of empagliflozin in reducing hospitalization for heart failure was totally independent of the glycemic control. It was clear from the early divergence of the curve and from the subgroup analysis as that HbA1c with the p-value for interaction is non-significant. Also, the effect of empagliflozin on cardiovascular death and hospitalization for heart failure is consistent in patients with or without baseline heart failure. You can see the overall benefit in favor of empagliflozin regarding the cardiovascular death in all patients, and regardless if the patient baseline having heart failure or no. The same for the hospitalization for heart failure. The benefit is there regardless if the patient have baseline heart failure or no. To summarize the most important figures or benefit from the empagliflozin in the EMPA-REG outcome trial, that empagliflozin was associated with 14% 3-point MACE reduction, 38% relative risk reduction in cardiovascular death, and 35% relative risk reduction of hospitalization for heart failure, and 32% relative risk reduction in all-cause mortality. And this result was consistent across all the subgroup analysis in the study population. So this was an example of the randomized controlled clinical trial. Do we have similar evidence from the real world and practice? The EMBRACE trial included analysis of more than 200,000 patients from US database, and patients with type 2 diabetes who are on new user for empagliflozin versus DDP4 inhibitors. Most of the analysis is going on, will be complete by the year 2021, but we have here the impact of empagliflozin on the hospitalization for heart failure. We can see here that there is 44% relative risk reduction of hospitalization for heart failure with the empagliflozin compared to the DDP4 inhibitors. And this matches the outcome from the EMPA-REG outcome trial. So we can surely say that the benefit of empagliflozin, it will be evident in our routine clinical practice as shown in the real world study here. The empagliflozin hospitalization for heart failure result in the EMBRACE trial, it matches all the result of the 3 major trials of the commonly used SGLT2 inhibitors, either the empagliflozin, as shown here in red in the EMPA-REG outcome trial, the dapagliflozin, and the canagliflozin. And essentially, if you look at the lower graph, that is for EMBRACE real-world study, that the benefit of reducing heart failure hospitalization with empagliflozin is there, whatever the patient is having underlying cardiovascular disease or not having underlying cardiovascular disease. So, from the cardiovascular outcome trial regarding the major adverse cardiovascular events, some studies have shown benefit of some agents like empagliflozin and canagliflozin, and also showed benefit of some GLP-1 receptor agonists like liraglutide, albiglutide, semaglutide, and dulaglutide. However, it was the MACE was neutral outcome for the dapagliflozin and some other agents. And regarding the hospitalization for heart failure, the benefit was evident for the empagliflozin, dapagliflozin, and canagliflozin. However, it was neutral for most of the GLP-1 receptor agonists. And important to mention here that saxagliptin from the DDP4 showed harm of increasing heart failure in the cardiovascular outcome trials. So regarding the completed studies of the major adverse cardiovascular events, we can see that the 3 agents, empagliflozin, dapagliflozin, and canagliflozin, have proved safe. But empagliflozin and canagliflozin have also shown some benefit in cardiovascular outcome. Regarding the cardiovascular death, from the completed trial of the SGLT2 inhibitors, we can see that clearly that the empagliflozin in the EMPA-REG outcome trial have shown favorable effect in cardiovascular death. Regarding all-cause mortality, all the three agents had shown safety, but again, the empiric outcome trial proved that empagliflozin have significant superiority over the standard of care, improving less all-cause mortality. What about the other important hard point? We talk about the cardiovascular mortality, all-cause mortality, and hospitalization for heart failure. What about the heart kidney outcome and albuminuria in the completed cardiovascular and cardiorenal and heart failure trial? Regarding the heart kidney outcome, we mean by doubling of the serum creatinine, increasing more than 40%, development of macroalbuminuria, progression to end-stage kidney disease, and mortality from kidney disease. It was clear that the empagliflozin, canagliflozin, and dapagliflozin, the three SGLT2 inhibitors, have proven benefit in this regard. And that the GLP-1 receptor had proven neutral, also including the linagliptin had proven neutral for this context. What about the prevention of albuminuria? Again, all the three SGLT2 inhibitor and some of the GLP-1 receptor agonists and the linagliptin had shown to be of benefit in reducing albuminuria. Empagliflozin had significantly reduced the relative risk of incident or worsening nephropathy compared to the standard of care. We can appreciate that there is 39% relative risk reduction of incident or worsening nephropathy. And again, diversion of the curve started early after a few months from the intervention. So the heart kidney outcome for the SGLT2 inhibitor and GLP-1 receptor agonist and DD4 is shown here together. It is clear that the SGLT2 inhibitor have proven to be of preventive and protective effect on the heart kidney outcome, while the GLP-1 receptor agonist and the DD4 inhibitor are neutral in this regard. Of course, it is important here, we are not comparing same studies. These studies are totally or significantly different in the methodology and the inclusion criteria. So we are not comparing molecule to molecule, and the difference in the inclusion criteria and methodology should be considered always when we interpret these studies. So regarding the dosing and administration guidance, we should be aware about some important points. The recommended dose to start with for the empagliflozin is 10 milligram, and for the dapagliflozin is 10 milligram once daily, of course, and for the canagliflozin 100 milligram. In case we need better glycemic control, we might increase the empagliflozin from 10 to 25 milligram once daily, and the canagliflozin from 100 to 300 milligram once daily. But for the dapagliflozin, we have only single concentration 10 milligram once a day. Women who are pregnant or nursing and people with age less than 19 or older than 85 in general should not use SGLT2 inhibitors. It's important to remind the patient that the tablet should be taken with or without food. And if one dose is missed and the patient remember within less than 12 hours, he should take this medication, and he should not double dose in the same day. And there is some, of course, regarding the safety issue, the SGLT2 inhibitor have proven safe compared to placebo in terms of the hypoglycemia, aglycemic ketoacidosis, bone fractures, urinary infection even, perhaps with some more tendency of genital infection. But it looks that, for example, in our population, Saudi Arabia and most of the Arab and Muslim countries, due to the different hygienic habits, this incidence of fungal infection in the genital areas is likely to be much lower than that in the other countries. So to summarize, the evolution of glucose lowering therapies based on the inclusive evidence of cardiovascular safety warning with older glucose lowering agent, the FDA, American FDA at 2008 had mandated that new agent should demonstrate cardiovascular safety through cardiovascular outcome trials. And the cardiovascular outcome trial, thanks to it, have shown that there is some new agent that can provide clear cardiovascular and renal protective and favorable outcome, regardless or independent from its glycemic control. Accordingly, we'll find clearly in the coming presentation that society recommendations and the clinical guidelines and the position statement had been updated to reflect the latest evidence of reducing the cardiovascular mortality for patients with type 2 diabetes. Not only that, but there is a lot of ongoing trials on the SGLT2 inhibitor that will continue to add to the evidence base, including investigating their effect on heart failure, either HFrEF, and we have some completed study like the DAPA-HF trial, and very soon we'll have within maybe 1 or 2 months the similar study for the empagliflozin, the embryo reduced, and also for the chronic kidney disease outcome in patients not only with type 2 diabetes, but even there is evidence of benefit in patients who are not diabetic. I might say that SGLT2 inhibitors are essentially cardiological drugs with respect to our colleagues in endocrinology, and very soon we might share by using it to protect our patient more and more, regardless of the patient having diabetes or no. And thank you very much for your attention.
Thank you very much, Dr. Ali, for this great presentation. Thank you very much, Dr. Ali, for this great presentation. I would like to remind all participants that we will answer all the questions at the end of the second lecture. So after we heard the cardiology view, I think it's time to hear the endocrinology view of this two great classes, especially SGLT2 inhibitors. As we know, many guidelines has been updated to reflect the new evidence that SGLT2 inhibitor has a role in managing patients with diabetes. Without further ado, it's my pleasure to introduce Dr. Raed Al-Dahash, who is a consultant division of endocrinology, Department of Medicine, King Abdulaziz Medical City National Guard Hospital. He's the head of endocrine division and diabetes center, Department of Medicine, King Abdulaziz Medical City National Guard in Riyadh. He's also assistant clinical professor in King Saud bin Abdulaziz for Health Sciences University and a member of National Center of Diabetes and Saudi Health Council. So Dr. Raed, I'll give you the floor.
Thank you, Dr. Abdullah, for your introduction. I will talk today about the guidelines. So as you know, the cardiovascular disease, it occurs 10 to 15 years earlier in the patient with diabetes, comparing with those patients with non-diabetes. Most of the patients with type 2 diabetes, usually they die from cardiovascular disease, as you know. So if we make the diabetes as a major cardiovascular risk factors, we can make it in 3 categories: very high risk and moderate risk. Those very high risk, those patients with diabetes and established cardiovascular disease, and or other target organ damage, or 3 or more major risk factors, or early onset type 1 diabetes of long-term duration, like 20 years or more. Those with very high risk, those with diabetes more than 10 years or equal, without target organ damage, plus any other additional risk factors. Young patients, those with type 1 and their age less than 35, or type 2 less than 50, with a duration of diabetes less than 10, without other risk factors, they are moderate. So now we will talk about evidence of evidence of cardiovascular disease, of SGLT2 and GLP-1 outcome trials. And this is, by the way, lead to major update in clinical recommendation and guidelines. And these studies start from 2015, once the empiric outcome came, then the leader, sustain, and so on, till 2020. And the guidelines is changing according to this study. I will show it to you in next slides. So the guidelines is changing in ADA and other guidelines, if we're talking about diabetes. Also, the guidelines of cardiovascular disease, heart failure, is also changing. They add SGLT2 as one of the classes to be treated for heart failure, for example. and to protecting cardiovascular disease. Also, if we're talking about diabetes kidney disease, SGL2 is one of those point to be mentioned in the recommendation. I will show it to you in the slide. So in ADA, the ADA, if I take the journey from 2016 to 2020, if we start from 2016, when the first, EMPA-REG trial came, they said SGL2 inhibitor providing insulin-independent glucose lowering, and these agents providing modest weight loss and blood pressure reduction. 2017, they said empagliflozin or liraglutide should be considered as they have been shown to reduce cardiovascular and all-cause mortality. 2018, the statement changed to be incorporate an agent proven to reduce major adverse cardiovascular event and cardiovascular mortality, currently empagliflozin and liraglutide. 2019, the SGL2 or GLP-1, they demonstrated cardiovascular benefit, and this is recommendation level A. So they make the statement, atherosclerosis cardiovascular disease at higher risk of heart failure or in whom heart failure coexisting, SGL2 inhibitor are preferred. For patients with type 2 and chronic kidney disease, consider using of SGL2 or GLP-1 shown to reduce risk of chronic kidney disease, progression, cardiovascular event, or both of them. In 2020, the statement changed to be, they said, SGL2 or GLP-1 with demonstrating cardiovascular benefit are recommended independent of hemoglobin A1C. And this is, by the way, level A recommendation. So they said in patients with type 2 diabetes and established heart failure, SGL2 inhibitor may be considered to reduce risk of hospitalization for heart failure. For patients with type 2 diabetes and diabetic kidney disease, consider using of SGL2 inhibitor to reduce risk of chronic kidney disease progression, cardiovascular events, or both of them. In patients with chronic kidney disease who are at increased risk of cardiovascular event, using of GLP-1 may reduce risk of progression of albuminuria, cardiovascular event, or both of them. Now, if we're talking about ADA guidelines and the recommendation to be included in cardiovascular disease and kidney disease risk management. If we start to talk about metformin, as you know, metformin is standard of care to treat type 2 diabetes, and usually we start with this medication. So in ADA standard of medical care in diabetes 2020 guidelines, the metformin, as you know, the efficacy is high. Hypoglycemia, there is no hypoglycemia. Weight change is neutral. Atherosclerosis cardiovascular disease, potentially benefit. Heart failure, neutral. Progression of diabetes kidney disease is neutral. What about SGL2? Efficacy, intermediate. Hypoglycemia, there is no risk of hypoglycemia. The weight change, there is weight loss. And atherosclerosis, they have proven benefit, especially empagliflozin and canagliflozin. The heart failure, having benefit in EMPA, CANA, and DABA. Progression of diabetes kidney disease, there is benefit in CANA and EMPA and DABA. What about GLP-1? The GLP-1, the efficacy is high. The hypoglycemia, there is no hypoglycemia. The weight change, there is showing, good weight loss. Atherosclerosis cardiovascular disease, lixisenatide is neutral, but there is benefit, indication of reducing cardiovascular event in liraglutide and other medication in this group. Heart failure is neutral. Progression of diabetes kidney disease may be in liraglutide. So in the guidelines in 2020, they said type 2 diabetes who established atherosclerosis cardiovascular disease or indicator of higher risk establishing kidney disease or heart failure, SGL2 inhibitor or GLP-1 with demonstrated cardiovascular benefit is recommended as a part of glucose lowering regimen independent of hemoglobin A1C. For patients with type 2 diabetes, diabetic kidney disease, consider using of SGL2 inhibitor in patients with GFR more than 30 and urine albumin creatinine ratio more than 30, particularly if they are more than 300, reducing risk of chronic kidney disease progression, cardiovascular event, or both of them. In patients with chronic kidney disease who are increasing risk of cardiovascular event, using of GLP-1 may reduce risk of progression of albuminuria, cardiovascular event, or both of them. Now, the IDA guidelines recommending heart failure is important type of cardiovascular disease to consider and demonstrating optimal type 2 treatment. They said in patients with type 2 diabetes, established cardiovascular disease, multiple atherosclerosis cardiovascular risk factor, or diabetic kidney disease, SGL2 inhibitor with demonstrating cardiovascular benefit is recommended to reduce risk of MACE and hospitalization for heart failure. And this recommendation is class A. In patients with type 2 diabetes and established atherosclerosis cardiovascular disease, or multiple risk factor for atherosclerosis cardiovascular disease, GLP-1 with demonstrated cardiovascular benefit is recommended to reduce risk of MACE, and this recommendation is class A. Patient with type 2 diabetes and established heart failure, SGL2 inhibitors may be considered to reduce risk of hospitalization for heart failure. Now, they're talking about patient with type 2 diabetes and diabetes kidney disease, consider using of SGL2 inhibitor with GFR more than 30, urine albumin creatinine ratio more than 30, or more than 300 to reduce risk of chronic kidney disease progression, cardiovascular event, or both of them. In patient with chronic kidney disease or at risk of cardiovascular event, using of GLP-1 may reduce risk of progression of albuminuria, cardiovascular event, or both of them. Now the guidelines, the ADA-ESA guidelines recommendation, the choice of second-line therapy should be based on assessment of atherosclerosis, cardiovascular disease, and heart failure. So as you know, the first line of treatment is metformin and comprehensive lifestyle. Then after that, try to check this patient having atherosclerosis predominant or heart failure or kidney disease predominant. So if it's atherosclerosis, cardiovascular disease predominant, so choosing GLP-1 to prove cardiovascular benefit, or SGL2 to also proving cardiovascular benefit if GFR is adequate. In heart failure or chronic kidney disease predominant, we prefer SGL2 inhibitor with evidence reducing heart failure and chronic kidney disease progression if GFR adequate, or you can consider GLP-1 to prove cardiovascular benefit if there is contraindication of SGL2. Also, the ADA-ASD 2019 consensus report update, they said SGL2 inhibitors are recommended in patients with type 2 diabetes and heart failure, particularly those with heart failure with reduced ejection fractions, to reduce hospitalization for heart failure and MACE and cardiovascular death. And they said SGL2 inhibitor should be used to prevent hospitalization for heart failure, MACE, cardiovascular death, and the progression of chronic kidney disease in patients with type 2 diabetes and chronic kidney disease. So these recommendations have been also incorporated in ADA standard of care in diabetes 2020 and consider conjunction with ADA-ASD guidelines 2018. So now, in 2018, ACC expert consensus decision pathway for patients with type 2 diabetes, they said the treatment algorithm should be used alongside established risk factor modification guidelines for preventive of MACE in patients with type 2 diabetes should also be applied in context of guidelines directed diabetic care. So the key element here, the patient-centered care, shared decision-making and integrated across disciplines and patient care rules. So they try to make sure what is the clinical patient decisions to which select either SGL2 or GLP-1 depend on patient situation and patient disease, either cardiovascular or kidney disease. So in this guidelines also, they're talking about at the time of clinical follow-up visit in patients with type 2 and atherosclerosis, cardiovascular disease, at the time of diagnosis, if the patient having clinically atherosclerosis, cardiovascular disease, and he's having type 2, the drug regimen should not be included if there is no benefits. So if there is benefits of cardiovascular, you should give GLP-1 or SGL2, depend on diagnosis. Also, after admission, if the patient with atherosclerosis, cardiovascular disease, or diabetes should be reassessment, in the risk-benefit profile for the patient to giving empagliflozin as a preferred choice for one of the SGL2 inhibitors to treating patient with type 2 diabetes and atherosclerosis, cardiovascular disease. The ESC recognized the paradigm shift in glucose-lowering treatment following the recent cardiovascular outcome trials. They said, for first time, we have evidence from several cardiovascular trials that indicated cardiovascular benefit from using SGL2 inhibitor and GLP-1 in patients with cardiovascular disease or at higher risk for higher cardiovascular risk. So now the guidelines recommended glucose-lowering therapy with proven cardiovascular benefit in patients with atherosclerosis or very high cardiovascular risk. So the choosing of drug to reducing cardiovascular event in patients with type 2 diabetes should be prioritizing based on presence of cardiovascular disease or cardiovascular risk. There is many cardiovascular trials suggest that SGL2 inhibitor and GLP-1 should be recommended in patients with type 2 diabetes with prevalent cardiovascular disease or very high risk cardiovascular disease, whether the treatment native or already in metformin. So now they're talking about if the patient already native, he's not in any medication, you can, if there is higher risk, you can start with SGL2 or GLP-1 as a monotherapy to start with, or adding therapy after metformin. So the metformin was similarly present in the active and placebo group of recent cardiovascular trials. It is unlikely to explain beneficial effect of a newer drug under testing. So you can start, if the patient atherosclerosis, cardiovascular disease, with SGL2 inhibitors as a monotherapy from the start, or you can add it to metformin if the patient already in metformin. If you're reaching the goals, or you can add other, medication of diabetes to reaching the goal, then third therapy, and so on. Now the guidelines, the ASC guidelines on diabetes and pre-diabetes cardiovascular disease in 2019 tried to be specific, the medication, and try to make the indication. By the way, the green the green color here, this is class recommendation is 1, and this color, the yellow is 2A, and the orange is 2B, and the red is 3. So if we're starting with glucose lowering treatment, they said EMBA, CANA, and DABA are recommended in patients with type 2 diabetes and cardiovascular disease at very high cardiovascular risk to reduce cardiovascular events. And EMBA is recommended in patients with type 2 diabetes and cardiovascular disease to reduce risk of death. Liraglutide, semaglutide, and dulaglutide are recommended in patients with type 2 diabetes and cardiovascular disease at higher cardiovascular risk to reduce cardiovascular event. Liraglutide is recommended in patients with type 2 diabetes and cardiovascular disease at very high risk to reduce risk of death. Saxagliptin is not recommended in patients with type 2 diabetes and higher risk of heart failure, and there is contraindication to be used in those patients. Diabetic with reducing heart failure risk, to reduce diabetic treatment to reduce the heart failure risk, they said SGL2, EMBA, CANA, DABA recommended to reduce risk of heart failure hospitalization. Metformin should be considered in patients with diabetes and heart failure is if GFR more than 30. GLP-1, DPP-4 inhibitor, CETA and LINA have a neutral effect on risk of heart failure and may be considered. Insulin treatment in heart failure may be also considered and safe. DDP4 inhibitors, saxagliptin in heart failure is not recommended. TZDs like pioglitazone, rosiglitazone in heart failure are not recommended. The management of CKD, chronic kidney disease, with diabetic patient, SGL2 are recommended to reduce progression of diabetic kidney disease. And this is, by the way, class A recommendation. Now they try to be more specific in heart failure patient and what's the treatment to reduce the risk of. They said SGL2 inhibitors, either EMBA, CANA, and DABA, recommended to lower risk of heart failure hospitalization in patient with diabetes. This is class recommendation 1 and level of evidence A. So 1A, metformin should be considered for diabetic patient with heart failure if GFR stable or more than 30. GLP-1 have a neutral effect on risk of heart failure hospitalization and may be considered for the diabetes management in patient with heart failure. DDP4 inhibitor, sitagliptin, linagliptin, have a neutral effect on risk of heart failure hospitalization and may be considered for diabetic treatment in patient with heart failure, except for saxagliptin. Insulin may be considered in the patient with advanced systolic heart failure with reduced ejection fraction. TZDs are associated with increased risk of incidence heart failure in patient with diabetes. DDP4 inhibitor like saxagliptin is associated with increased risk of heart failure hospitalization and is not recommended for diabetes treatment in patient at risk of heart failure. Now the ACC providing consideration of treatment with SGL2 and monitor with those patient type 2 hospitalization for heart failure. They said patient should be assessed for diabetes and other comorbidities during initial evaluation and addressed throughout heart failure hospitalization and discharge planning in patient with diabetes and hospitalization for heart failure, monitoring hyperglycemia throughout hospitalization, and avoid TZDs, consider metformin and SGL2 inhibitor. If SGL2 inhibitor are started in hospital, carefully consider should be given to dose of diuretic therapy. So these agent potent osmotic diuretic effect. So be careful, use with each other. Patient with hyperglycemia and hospitalization, close follow-up with primary care provider, endocrinologist, or diabetic educator is recommended within 2 to 4 weeks, especially when medication has been changes, so they can monitor it earlier of starting of treatment. Now the European Renal Association and European Dialysis and Transplant Association consensus statement, they said they recommend SGL2 inhibitor and GLP-1 use for patients with type 2 diabetes and chronic kidney disease, not in hemoglobin A1C target after first step treatment. So they said using of SGL2 inhibitor with evidence for cardiovascular and cardioprotection and nephroprotection, given that eGFR within license range. And they said also, switching from one glucose lowering drug that does not confirm cardiovascular and nephroprotection within SGL2 inhibitors can be done, in line with current diabetes recommendation. So patient chronic kidney disease achieving hemoglobin A1C target and combined therapy with metformin. So if you want to add, you can add or switch to one of these SGL2 inhibitors. Now they're talking about recommendation in those GFR from 30, risk of kidney endpoint, GFR from 30 to 90. They said it's recommended that the patient with diabetes and screened annually for chronic kidney disease by assessment of GFR and urine albumin creatinine ratio, tight glycemic control, target less than hemoglobin A1C less than 7 is recommended to decrease microvascular complication in patient with diabetes. Also, they recommend that the patient with hypertension and diabetes treated in the individual manner, target systolic blood pressure should be 30 or less than 30, but not less than 120. In elderly patients, systolic blood pressure goal from 130 to 40. We are relaxing in this. ACE or ARBs is recommended for treatment of hypertension in patients with diabetes, particularly if the patient having proteinuria, albuminuria, or left ventricular hypertrophy. SGL2, either IMPA, CANA, DABA, associated with lower risk of renal endpoint and recommended if GFR from 30 and less than 90. Treatment with GLP-1 like liraglutide, semaglutide, associated with lower risk of renal endpoint and should be considered for diabetes treatment if eGFR more than 30. So if we're talking about number need to treat to prevent one death across landmark trial patient with higher cardiovascular disease, we will find empagliflozin about 25 and the liraglutide about 98. So FDA and European label indication for empagliflozin after EMPA-REG outcome trial. In the FDA, they said empagliflozin is a SGL2 inhibitor indicated to reduce risk of cardiovascular death in adult patients with type 2 and established cardiovascular disease. In European label, they said empagliflozin is indicated for treatment of adult with insufficiently controlled type 2 diabetes as adjunct to diet and exercise. A monotherapy when metformin is considered inappropriate due to intolerance or in addition to other medicine product for treatment of diabetes. For study result with respect to combination effect on glycemic control and cardiovascular event. So both improvement of glycemic control and reducing cardiovascular mortality and morbidity are integral part of treatment of type 2 diabetes. So in summary, after understanding the clinical guidelines, what we showed to you, recent outcome trials having relevant that most of glucose lowering agents have beneficial effect on cardiovascular outcome and the protective effect on kidney outcome. Global clinical guidelines and recommendation for patients with diabetes and cardiovascular disease, heart failure or diabetic kidney disease has been updated as a result of evidence from recent outcome trials. To date, empagliflozin, canagliflozin, dapagliflozin, liraglutide, and semaglutide and dulaglutide have been updated FDA and or European label evidence from recent outcome trials. So now evidence-based guidelines proving opportunity to help improving outcome in patients with type 2 diabetes. Thank you so much.
Okay, thank you very much, Dr. Raed, for this great lecture. So I will go through the questions and I will indicate if this is for Dr. Ali or Dr. Raed. But first of all, I noticed there's a lot of participants who ask about CME. So yes, there is 2 CME for this event, and Saudi Heart Association will take care of that based on the registration. So let me just find the first question. So Dr. Ali, one of the participants asked the target of blood pressure of 130/80 is regardless of age, or there is different target of blood pressure for patients more than 80 years old?
Okay, so talking about diabetes, of course, overall we know that the guidelines for hypertension management recommended that the majority of our patients should achieve blood pressure less than 140/90. However, we have some special population, patients who have albuminuria or have concomitant chronic kidney disease. There's recommendation to go lower with blood pressure, and we start treating hypertension with blood pressure less than 130/80 as per guidelines like the NICE guidelines, and even some population for the European Society of Cardiology. Regarding patient elderly, of course, we have to consider the age, we have to consider the comorbidity. Generally, we consider blood pressure to not to be, for the very elderly people, we might starting treating blood pressure with more than 150/90. But again, you have to individualize the situation and to judge the patient by more close follow-up to see the response, to avoid some medication like aggressive vasodilators or aggressive diuretics in your population, in your special patient, and to monitor the effect in your individualized case.
Excellent. So, Dr. Raed, one of the participants asked if they can use GLP-1 and SGLT2 together in the same patient.
Yeah, they can be used if there is indication to be used. Yes, they can be used and safe to be used with each other.
Okay, excellent. Dr. Ali, I think this is a very common question. They ask about aspirin use routinely in long-standing type 2 diabetes patients without evidence of cardiovascular disease. What do you think about that?
This question recently we have a solid confirmed answer. No, a patient who have no evidence of atherosclerotic cardiovascular disease, and especially patients who have no high estimated atherosclerotic cardiovascular risk, the estimated cardiovascular risk is not high. These patients are not recommended to use routine aspirin. Most of the consistent result from large studies is that it might be associated with harm more than benefit. So there is no rationale to use aspirin routinely in these patients.
Okay, excellent. Dr. Raed, there's a question about patient with metformin and uncontrolled LDL. Should they change the treatment choice to prevent possible atherosclerosis?
You mean to add either if the patient is higher risk of atherosclerosis, cardiovascular disease, and he's, for example, obese or overweight, I think using of GLP-1 is one of the good option for this patient. Even if he's not controlled, adding SGL2 also after that, it will be giving for those patients with higher risk of cardiovascular disease.
Okay. So Dr. Ali, this patient, this participant asked, try to read the question. Can it prevent chances? I think they're asking if empagliflozin can prevent chances of hospitalization of heart failure.
Yes, definitely. We presented the clear slide about that in the empiric outcome trial that included population. At the entry time, only around 10 to 12% of the patient had heart failure, okay? And during the follow-up, more than 10% developed new heart failure in the standard of care arm. The patient who used empagliflozin on top of standard of care had 35% relative risk reduction of hospitalization for heart failure. So the answer is yes. Now we have this agent that prevent the development of heart failure and also reduce significantly the hospitalization for heart failure.
Okay, excellent. So Dr. Raed, this participant asked, since cardiovascular events are considered as major issue in type 2 mortality, can we consider metformin plus SGLT2 inhibitor as initial treatment, regardless of the presence of high risk features of cardiovascular disease?
I mean, for this patient, if you want to start, you should, first of all, you should be considered GLP-1 as a first choice. Then after that, if you want to add, you can add SGL2 for atherosclerosis cardiovascular disease. But if these patients having chronic kidney disease or heart failure, if this is the case, we can use SGL2 inhibitor as a first treatment of choice, then adding GLP-1 after that treatment.
Dr. Ali, this is a question. So either of you would like to answer if we can use IMPA in patients with HOCM with diabetes. So patient, I think, having hypertrophic cardiomyopathy and diabetes, can we use IMPA?
It's okay. Perhaps I can start. Dr. Raed may like to add. So generally, patient with diabetes and evidence of atherosclerotic disease or established disease, this is the group of patients that's proven to get benefit from the empagliflozin. We have to respect the entry criteria is the empiric outcome trial. 99% of the population had established cardiovascular disease, okay? Because you have to remember that when similar agent, which is the dapagliflozin, when involved in the DECLARE study with not that high enrollee or enrolled patient with established cardiovascular disease, it did not show improvement of cardiovascular mortality. So we have to respect that. If a patient with HOCM have established cardiovascular disease, This patient, yes, I might, of course, in my practice, I will give him empagliflozin, but I have to be cautious that empagliflozin and other or SGLT2 inhibitor, the main mechanism of action is through reducing absorption of the glucose and sodium as well. So it has some diuretic effect. And we have to remember that patient with HOCM, we have to be cautious in volume depletion. So we have to monitor if the patient is using another diuretic agent to reduce this agent and to follow up the blood pressure of this patient, at least initially carefully, because most of the patients of the SGLT2 inhibitor, they face the increased diuresis at the starting of the therapy. But after a short time, it looks that there is adaptive mechanism that they don't face any more diuresis compared to the finding when they start the therapy. So the answer is yes, as long as they establish cardiovascular disease, but be cautious with using association of other diuretics.
Okay, so do you have anything to add, Dr. Raed, for this question?
Yeah, I agree with Dr. Ali, what he's mentioned. Yes, I mean, to be cautious if he's using, SGL2 with other diuretics medications, should be cautious and should the patient be monitoring for electrolyte disturbance or for, dehydration.
Okay, Dr. Raed. So this question, participant asking, which is better for patients with type 2 diabetes who has CKD, chronic kidney disease, and cardiovascular disease? Is it GLP-1 or SGLT2, or they are equal?
Yeah, we said, in the diagram that if the patient having chronic kidney disease using of, and having heart failure, using of SGL2 is preferred. If this patient having atherosclerosis, cardiovascular disease, using of GLP-1 is preferred. If the patient having both at the same time, if this is the question, we can use both of them for this patient. And there is no contraindication to add them with each other. Sometimes there is another factor to be considered for the patient. For example, if the patient is willing to taking injectable therapy, some of the patients, they don't want to take injectable therapy. So we should be consider this. Also, there is one of the point, the GFR. As you know, if the GFR less than 30, there is some limitations of, SGL2 to be used.
Thank you. Dr. Ali, can we use SGLT2 inhibitor in heart failure patients without coexisting diabetes?
Okay. So till now, we don't have label indication in this context. Till now, we don't have certification to start SGLT2 inhibitor for patients with heart failure without diabetes. But I promise you, you will have this as class 1 indication very soon. Very soon. The coming update of heart failure, I'm not just a prophecy, but it is almost sure. Why? We have the DABA heart failure trial, the DABA HF trial for patients with heart failure with reduced ejection fraction. This study included more than 50% of its population, patients are not diabetic. And to tell you that actually the robust benefit of reducing heart failure hospitalization, cardiovascular mortality, and all-cause mortality was totally significant, independent of having or not having diabetes. It was 25% relative risk reduction if the patient is having diabetes, and 27% relative risk reduction if the patient does not have diabetes. I'm talking about all-cause mortality, cardiovascular mortality, and heart failure hospitalization. Very hard endpoints. The good news is that the EMBRO reduced the trial, which is almost a similar study that involved empagliflozin in patients with reduced ejection fraction, patient ejection fraction less than 40, and is comparing empagliflozin in this category on top of standard therapy versus standard therapy alone to evaluate the development of cardiovascular death or hospitalization for heart failure. The study is about to be announced in the coming European Society of Cardiology, and it looks that we are going to get the same robust benefit as happened in dapagliflozin for the DABA HF. Now, having two well-conducted randomized controlled clinical trials with the same benefit, this should, as soon as possible, change the guideline so that our patients who have HFrEF without diabetes to start using SGLT2 inhibitors. Another category of heart failure is the heart failure with preserved ejection fraction, the HFpEF. Currently, there is two major trials running. One for the empagliflozin is the embryo reduced, and another one for the dapagliflozin is the deliver study. But having the result still need time, and we have to wait to find result. We hope that these molecules will also get benefit in this group of patients, this phenotype of HFpEF. Actually, till now, we have very limited medication option.
Okay. Dr. Raad, this question, this participant asked about SGLT2 data regarding bladder and breast cancer concerns. Is there anything concerning so far about that?
Yeah, there is concerning when, to use at the beginning of dapagliflozin to be in, there is concerning about urinary cancer, especially if you give this, if you give dapagliflozin with, TZDs. So, but after there was concerning at the beginning of treatment, but after using of medication till now, there is no evidence that it will increase of urinary bladder risk.
Excellent. So this is just came in, Dr. Raad, again. I think this is a case. So this is 59-year-old female with recurrent severe UTI requiring hospitalization and a history of MI with PCI and stenting last year, and A1C around 7.3, currently on Metformin and Lantus. Do you recommend adding empagliflozin for such cases, given her recurrent history of UTI?
This patient, I think, the liraglutide or GLP-1, it should be considered as a first choice of treatment if you want to add from atherosclerosis cardiovascular point of view. Adding SGL2 with recurrent UTI, can be considered, but should be cautious because this patient having UTI, if it could be increasing risk of, risk of UTI. But GLP-1, I think, one of the first choice if this patient having stenting and atherosclerosis cardiovascular disease.
Good. So last question, Dr. Ali, if SGLT2 is contraindicated, is there any alternatives, especially for those who are nursing or above 85 years old?
Okay, so regarding the nursing, ladies, unfortunately, we don't have as a similar alternative, alternative oral glucose lowering agent that is safe in this category of people. But regarding the age, we reduce the slide that patient older than 85, we should not give them SGLT2 inhibitors. But I would like to tell you that the evidence of safety and benefit of the SGLT2 inhibitor is in evolution. I mean that, for example, we have in the DAPA heart failure trial, the enrolled patient without age limitation, and the evidence of benefit on the DAPA-HF trial had been very clear in patients above the age of 75. Okay, while you can find that in the slide I presented, patients older than 75 are relative contraindication for dapagliflozin. Okay, also in the deliver and to my knowledge in the embryo preserved, there is no upper age limit. So it looks by time the age limitation will be modified. So regarding the age, we have to respect the license till now. For all SGLT2, not more older than 85 to give, and for dapagliflozin, not older than 75. And we don't have, unfortunately, alternative to reduce cardiovascular outcome in patients with established cardiovascular disease in the nursing woman. Fortunately, women in the nursing age are very, very, very low or very unusual to have them with atherosclerotic cardiovascular disease.
I agree. Well, that was a very great 2 lectures. And I think we had a very good review from cardiovascular perspective and from endocrine perspective. And we shed light about potential benefits of SGLT2 and updates of guidelines to reflect the recent evidence. I would like to thank you, Dr. Raad and Ali, and on my behalf and Dr. Raad and Dr. Ali's behalf and Dr. Abdullah Al-Guayhas, I would like really to thank Boehringer Ingelheim and Saudi Heart Association for organizing this amazing event. I hope we have answered all the questions, and we highlighted the important points about SGLT2 and its potential in management of patients with type 2 diabetes. So again, I would like to thank you and thank the participant for being with us.
Yeah, I want to thank you, Dr. Abdullah, for chairing of this event. I want to thank Boehringer, Dr. Ali, and I want to thank those 2,500 attendees with us today.
Yes.
I mean, it's a huge number. I hope we give something to be benefit for them and addition for them. And I ask Allah subhanahu wa ta'ala for everybody to be safe from Corona, and please stay home and stay safe.
Thank you, Dr. Ali. Thank you, Dr. Abdullah. Thank you, Boehringer. Our mission here really is to exchange knowledge with our colleagues, and we are all aiming for the ultimate goal, better patient care. May Allah reward us for this intention. Thank you very much.
Thank you very much. Good night.